So which are the imaging tools we are having for imaging of chronic pancreatitis? Abdominal X-ray and ultrasound, they serve as a basic investigation just for the detection of changes of chronic pancreatitis. CT scan, it is a must investigation in each and every patient of chronic pancreatitis. And MRI, it is a more sort of problem solving modality, as well as it is very useful to detect early changes of chronic pancreatitis. So this is a classical case of chronic pancreatitis on X-ray abdomen, where we can see dense calcifications in the pancreatic parenchyma from the head to tail region. And this is very advanced case of chronic pancreatitis. Otherwise, it is very difficult to pick up a case of chronic pancreatitis on X-ray. In ultrasonography, ideally, we should have a fasting patient for better visualization of the pancreas. We can use sitting position of the patient with few sips of water to distend the stomach and use the fluid-filled stomach window for the visualization of pancreas and splenic window for the visualization of the tail of pancreas. Ductal dilatation and stones, as well as pancreatic parenchymal calcifications, these are the most specific findings on ultrasonography. Apart from that, we can see parenchymal heterogeneity, few of the echogenic foci with or without shadowing, lobularity and honeycombing. These findings are specifically seen on endoscopic ultrasound rather than transabdominal ultrasonography. So these are the examples of changes of chronic pancreatitis on ultrasound. Here we can see the pancreatic parenchyma is significantly heterogeneous, and there are multiple hyperechoic foci with shadowing, which are indicative of pancreatic parenchymal calcifications. And in this case, there is a massive ductal dilatation with presence of ductal calculi, which are also showing the acoustic shadowing. Yes, now moving to the CT scan, it is the most important modality for the evaluation of chronic pancreatitis. And in each and every patient in whom chronic pancreatitis is suspected, he should be subjected to the CT scan. It serves as a baseline investigation for the future investigations also, as well as for the comparison purpose and progression of the disease. So we are doing dedicated pancreatic phase protocol for the CT scan. And what are the features we are going to see in chronic pancreatitis? In initial phase, there is presence of pancreatic fibrosis as well as the inflammatory areas within the pancreas. So enhancement of pancreas is significantly heterogeneous because fibrotic parenchyma, it enhances on later phase, while edematous area or inflammatory areas, they enhance on earlier phase. This gives significant heterogeneous appearance to the pancreas. With the time, as the fibrosis advances, there is traction on ductal system and pancreatic duct starts to dilate with loss of its tapering in tail region. Due to fibrosis, the margins of pancreatic duct are significantly irregular. There is associated side branch ectasia, and there is formation of the strictures and alternating areas of stenosis and dilatation we can see. As the ductal pressure continues to rise, there is formation of the cystic areas in the pancreas, which may be smaller in earlier stage, and we can see large pseudocyst formation also in course of chronic pancreatitis. And the calcification and stones formation, they come later in the phase when the ductal drainage, it is severely impaired, proteinaceous material, it gets precipitated, and calcification and stone formation start within the parenchyma. And during all this process, there is severe parenchymal loss and atrophy of the parenchyma. But if we are seeing calcifications and stones within the pancreatic parenchyma, we are dealing a case which is severe in nature, as well as it must have a very long duration. So this is a classical case of chronic pancreatitis, and here we can see there is significant calcifications in the pancreatic parenchyma as well as significant ductal dilatation, and we can see stenosis in the neck region of the pancreas. And if we see the coronal reformated images on this, we can see significant dilatation of the duct and pancreatic parenchymal calcifications. And if we measure the pancreatic parenchyma on the either side of the duct, it is showing only 5 mm thickness. That signifies that the significant atrophy of the pancreas has set in. So this is another case of chronic pancreatitis where we can see dilatation of the main pancreatic duct with irregular areas of stenosis in between. There are very large calcification, and we can appreciate these calcifications on axial images also. This was actually a case of 23-year-old male presenting with tropical pancreatitis, non-alcoholic male. Sometimes the size of calcifications and stones, it can give idea about the etiology of the pancreatitis. In alcoholic pancreatitis and cystic fibrosis related chronic pancreatitis, they are usually small in size. In other hereditary forms of pancreatitis and tropical pancreatitis, it can grow up to 5 centimeter in size. And calcifications, they are usually seen early in the course of disease in alcoholic and hereditary pancreatitis, while it is relatively late in cystic fibrosis disease. We are using modified Cambridge classification system for grading the severity of chronic pancreatitis on CT scan. And grade 0, it is a normal, grade 0, it is normal pancreas. Grade 1, it is equivocal findings when we are not able to tell the changes are suggestive of chronic pancreatitis or not. The milder form, it is also labeled as the early changes of chronic pancreatitis on CT scan, and it should have 2 or more of the following features. Pancreatic duct dilatation, which is between 2 to 4 mm, ductal irregularity or variation of 1 to 2 mm, side branch ectasia, which is involving 3 or more branches, heterogeneous parenchyma due to pancreatic fibrosis, and cystic changes which are 10 mm or less in size. The moderate form of chronic pancreatitis, it has features of mild pancreatitis, plus there is MPT dilatation, which is greater than 4 mm in size. And in severe form of pancreatitis, there is stones, strictures, parenchymal calcification formation, cysts which are greater than 10 mm in size are seen, and severe ductal irregularities are seen. Now moving to the MR evaluation, we can do the conventional MR imaging with MRI abdomen as well as MRCP, and we can perform secretin MRCP in selected patients. In conventional MR abdomen and MRCP, we are acquiring T1 weighted image, T2 weighted image, diffusion weighted images, and 3D MRCP images for the visualization of pancreaticobiliary tree, and post-contrast T1 images for evaluation of pancreatic enhancement. Secretin MRCP can be done in few of the patients, and we should have the patient strictly NBM. First, we perform the conventional MRCP followed by injection of secretin, and then again the MRCP images are acquired. Just like CT scan, we are having modified MRCP Cambridge criteria for chronic pancreatitis. According to that, mild form of chronic pancreatitis is there when there is side branch ectasia of 3 or more side branches. Then moderate form of chronic pancreatitis is labeled when there is dilatation of MPD in addition to the side branch ectasia. And severe form of chronic pancreatitis when there are changes in addition to moderate form of chronic pancreatitis, obstruction, cysts, stenosis, and calculi formation within the pancreatic duct. So this is a classical case of chronic pancreatitis on MR images. Here we can see there is a ductal dilatation from head to tail region. It is associated with the side branch ectasia in head and tail region. And if we see the corresponding CT images, we can see faint calcifications in the pancreatic parenchyma. And on T2 weighted images, there is significant parenchymal loss on either side of the main pancreatic duct, which signifies the pancreatic atrophy. So with pancreatic atrophy, dilatation of the pancreatic duct, side branch ectasia, and calcifications of the pancreas. So this is a case of severe form of chronic pancreatitis. Now, use of T1 weighted image in diagnosis of chronic pancreatitis. These are useful for the detect the parenchymal changes of chronic pancreatitis. Usually the pancreas, it is just like liver or a little bit brighter than the liver on T1 weighted images. But in cases of chronic pancreatitis, it will be very much hypointense or darker as compared to the liver, as we can see in this case. On post-contrast images, usually the pancreatic parenchyma, it enhances very well in arterial phases, but in chronic pancreatitis due to fibrosis, it doesn't enhance on arterial phase, and it enhances in the delayed phases due to the presence of fibrosis. Fibrosis enhances in the later phase, and due to this, we can see these parenchymal changes. Now, use of the diffusion weighted images. Usually, this is the normal patient in the first 2 images. In this, we can see on T1 weighted images, the pancreas is just like liver parenchyma. And on diffusion weighted images, there is no restricted diffusion we can see in the pancreatic parenchyma. But in cases of chronic pancreatitis, this here we can see there is hypointense or darker appearing area on T1 weighted image, which is also showing restricted diffusion. So diffusion weighted images, they help to detect the parenchymal changes. Now secretin MRCP, in which patients we should perform the secretin MRCP? The patients, in patients in whom we can see the parenchymal changes on T1, T2 or diffusion weighted images, but we are not able to appreciate the ductal changes, we should perform the secretin MRCP. And second thing, if the clinical suspicion is very much strong and we are not getting the changes of chronic pancreatitis on routine imaging, we should inject secretin into patient. Now, this is a case of very early chronic pancreatitis where we can see the side branch ectasia within the along the main pancreatic duct. There are 4 side branches which are dilated. MPD is smooth, it is not significantly dilated. So this is a very early change of chronic pancreatitis. Second thing which we can evaluate with the secretin MRCP is exocrine function of the pancreas. Here we can see that the entire duodenum, it is opacified by the pancreatic secretion. On injection of the secretion, pancreas releases bicarbonate rich fluid, and if first part of the duodenum it is opacified by this fluid, we label it as a grade 1 exocrine function. For second part it is grade 2, and for third part it is grade 3. Grade 1 and grade 2 function, they are regarded as exocrine pancreatic insufficiency. Grade 3 is the sufficient pancreatic function. So with the secretin MRCP, we can evaluate early changes of chronic pancreatitis as well as exocrine function of pancreas. Now, as Dr. Prasad stated, there is commonly mass formation in the head region of the pancreas in chronic pancreatitis, which should be differentiated from the adenocarcinoma. So here is a case where we can see there is mass within the head region of the pancreas. And when we performed MRCP, we could see the ductal dilatation, side branch ectasia, as well as we could see that the duct is coursing very smoothly through the mass lesion. So this is a penetrating duct sign which indicates the presence of inflammatory mass rather than the adenocarcinoma. Now, this is a case where there is formation of adenocarcinoma within the chronic pancreatitis. Here we can see the calcifications, they are displaced towards the periphery of pancreas due to the mass effect by the lesion. There is also cutoff of the CBD and MPD by the mass lesion leading to the double duct sign. And teardrop SMB sign, this is due to the perivascular infiltration by the mass lesion, and this doesn't occur in inflammatory mass. So displacement of the calcification, double duct sign and teardrop SMB sign, these are the helpful signs to differentiate the adenocarcinoma from the mass forming chronic pancreatitis. So if at all we are having suspicion of chronic pancreatitis, we can go ahead with cross-sectional imaging, CT scan or MRI. And if we are not getting the changes, we can go further with endoscopic ultrasound or secretin enhanced MRCP. And if still we cannot detect the changes of chronic pancreatitis and clinical suspicion is strong, then we can go for the genetic testing and pancreatic histology. So I would like to conclude my talk with this slide. Thank you.